And finally, to talk about clinical networks, we have Perren Cobb, a professor of clinical surgery and director of the USC Critical Care Institute, and director of the Keck Surgical Intensive Care Unit from the University of Southern California.
Thanks, Laura. Can you hear me okay? Yeah, great. So one of the advantages of being on the planning committee is that we can build breaks in, and since everybody's been on time and we have a 30-minute break to follow, I've got 40 minutes that we can talk. No? I have 40 minutes to talk about this? Okay, I was going to ask Justin for that second slide deck I sent you, but I guess not. Okay, so I'm delighted to be with you here this morning. It's great to see everyone, and my charge for the next 8 minutes or so is to introduce the topic of clinical networks, in particular what is meant by clinical networks. As a scientist and as a clinician, we're going to bring it back to the patient to close this session. So I suggest we start with this. I don't want to stand in anybody's way. To start with this article, which was published in the journal a few years ago. It's entitled Research as a Part of Public Health Emergency Response, and it was written by Drs. Lurie, Collins, and Frieden, and others, the then directors of ASPR, the NIH, and the CDC. They wrote, you can see in quotes here, although responses to recent events have typically used the best available science at the time, additional research done in parallel with and after the response itself, ideally, as Carmen mentioned, in real time, is often essential to address the most pressing knowledge gaps presented by public health emergencies and to ensure that they are addressed by the time another similar disaster strikes. Emphasis added, recent events, however, have also illustrated gaps in the planning for and rapidly executing scientific research in the context of the disaster response. This came on the heels of H1N1, Hurricane Sandy, and it was 2 weeks before, somewhat ironically, 2 weeks before the marathon bombing in Boston. As Boris and Carmen mentioned, this is an all-hazards approach, whether it's H7N9 in the upper left, Ebola in the bottom right, Hurricane Sandy, Mother Nature, or whether it was the marathon bombing with an improvised explosive device or, God forbid, a nuclear device. This is an all-hazards approach that we're taking. In follow-up to the article, Dr. Lurie charged our group, the United States Critical Illness and Injury Trials Group, to gather individuals and subject matter experts from the federal government, from academia, and from community and industry to begin to identify what are the key questions with respect to research emergencies. What are the key questions that we need to be able to answer in response to any type of emergency across hazards? So we got these together and we came up with 6 questions that would be of interest to clinician end users and investigators, as well as those who are responsible for systems and operational evaluations. This was published in Critical Care Medicine a couple of years ago, and those questions include, what was the nature of the insult and the resulting phenotype? As a responder, what, if anything, did you have to do differently? For example, after the marathon bombing, we canceled elective surgery, which affected a large number of patients on that day. Did the diagnostic countermeasures and therapies work as expected or not? And what was the impact on the patient and care setting? From an operational standpoint, was there anything essential that you did not get that you really needed? And finally, based upon your experience, what would you imagine would be the best case or the worst case scenario that could happen next time? So if these are the key questions from which we're starting, how are we going to be able to answer these questions? We need to have the data to be able to answer those questions, and we need to have the infrastructure that will allow us to collect the data that allows us to answer these questions. As Carmen introduced, there's a lot of work and a lot of funding that's gone on under the general umbrella of the FEMC, the Public Health Emergency Medical Countermeasure Enterprise. The current state with respect to the network of networks that we've been building across these funding strategies includes the following: the new capability at a national network of acute and critical care research organizations of academic and community hospitals for adults and children, that is across the age continuum, as well as across the care continuum, from pre-hospital through rehab. We have the new capability of a rapid communication network with quarterly queries to assess national health system stress. We've developed infrastructure for prospective trials for national public health emergencies with use cases including seasonal influenza as one of our more predictable health system stresses, as well as anthrax, inhalational anthrax in particular, as a theoretical threat. We've developed national data coordinating centers. We've worked with local IRBs as well as national IRBs through the NIH Public Health Emergency Research Review Board, or the FERB. And we're coordinating these efforts in the States with our friends to the north in Canada and our friends to the south in Mexico for a North American critical care cooperative. And we're also partnering with international organizations who are trying to do the same thing in their respective countries. So if we look at a network of networks and say, where geographically distributed are these various research sites? In red are the sites of the United States Critical Illness and Injury Trials Group, recently rebranded as the Discovery Research Network of the Society of Critical Care Medicine. In yellow are the sites funded by the CDC of NETEC, the National Ebola Training and Education Center, and we have representatives here from both the Use It group and NETEC today. In orange are the sites for the Johns Hopkins University Research Network. In blue is the Pediatric Emergency Care and Research Network, the PCAR network. In green, the Pediatric Acute Lung Injury and Sepsis Network investigators. And in purple, the NHLBI-funded Prevention and Early Treatment of Acute Lung Injury Research Network, right? So what's striking if you look at this map? You can see that the U.S. is pretty well covered. Certainly there are areas and there are opportunities for better geographical representation, but the point I want to make is that we have a large number of centers that are interested in preparedness and response from a clinical research standpoint. These are investigators, scientists, administrators who are very motivated to do this. But there's not an opportunity for the leadership from these various groups to get together and to compare notes. What have we learned over the last year? How might we use the available resources in a more efficient manner? And that's something that needs to happen. Well, what now? The Planning Committee has been focused on this question for the last several months and have come up with several topics framed in a question that we thought might be appropriate to address over the next couple days. We need your input. What is the expected timeline, or the expected need and the timeline? What are the existing capabilities and available resources? I've touched on that a little bit. What are the existing gaps? And maybe most importantly, and Boris alluded to this, I'm always pushing the exercise piece, practice makes perfect. What steps are needed to close these gaps in the next 3 years? Now, some of you may know that next year is the 100th anniversary, it's certainly not a celebration, the 100th anniversary of the Spanish flu from 1918. Some of you may also know how many people were killed globally as a result of that. 50 million, 3% of the world's population at the time, right? These are the death rates shown here for New York, London, Paris, and Berlin. In October 1918, got up to 6% of the population died. So God forbid we should have something like that again. Many people say it's a question not if, but when. So if this were to happen next year with some evolving threat, would we be ready to collect data from the medical countermeasures that would be deployed at that point? My answer to that would be probably not. And if not, well, how could we spend the next year, for example, preparing for that? What sort of exercises could we do? And Boris, I appreciate him mentioning the F word, funding, for these types of activities. Finally, we're not the only group that has thought about this. These are a summary of key topic areas from a group that met 2 years ago here, supported by the IOM and the HHS. Maybe some of you were in that audience. And I would look at this list as far as key topic areas on which to focus for the future, as this is a good list. But I also have asked for permission to be a little provocative. I would also suggest we don't need another list. What we need is a game plan, an action plan on how to identify metrics for success for each of these or other topics that we might identify over the next couple days, and how we really push the discussion to the next level and say, yes, we're prepared. We're exercising, practice makes perfect, crawl, walk, run on a regular basis. Thank you for your kind attention. I'd be happy to take questions during the break here. Thank you.